Hello, I'm David Bull. I'm a medical doctor and a journalist, and I'm delighted to welcome you to this debate on hypoglycemia in diabetes, entitled Real World Experience and Prevention. Now, I can tell you we're not in any ordinary meeting because we are in Florida. We're in Orlando at the ADA, which is the American Diabetes Association. Now, as you can imagine, we are surrounded by world-class experts, so I've stolen 3 of the very best to be here with me tonight. So I'm really thrilled to introduce the Professor of Medicine and Therapeutics at the Chinese University of Hong Kong, China, Juliana Chan. Next to her, Professor of Endocrinology at the Universidad Autónoma de Nuevo León in Mexico, Fernando Lavalle.
Thank you, David.
And last, but by no means least, Professor of Medicine and Endocrinology and Postgraduate Dean, Doctoral School of Health, Life and Environmental Sciences at the University of Yaoundé in Cameroon, Jean-Claude Bagna.
Thank you.
Well, it's wonderful to see you all here. Thank you very much indeed for taking the time to come and talk to me. Perhaps we could start with the many faces of hypoglycemia. And Juliana, perhaps you could kick us off by talking about the pathophysiology of hypoglycemia itself.
Well, to put it simply, the blood glucose is maintained at all times between 4 and 8 millimoles per liter, whether you eat or you don't eat. And that relies on very interactive mechanisms, a balance between insulin, which is the only hormone that will reduce glucose. But because glucose is so important as an energy substrate that we need a lot of stress hormones to maintain the glucose even when you are not eating. So based on that premise, people who've got hypoglycemia either have inappropriate insulin action or they have a defective counter-regulatory or stress hormones.
Right.
And in most situations, I think drug-induced hypoglycemia is the most important cause for hypoglycemia. Okay, yeah, and then the situation, there might be some situations where people do not have enough adrenaline or do not have enough cortisol, which actually cause the hypoglycemia, or they have a problem in the pancreas that produce excessive insulin that give rise to hypoglycemia.
Okay, so but in real terms, who is most likely to suffer from hypoglycemia in terms of the ranking?
Of course, people who are treated with drugs, okay, particularly with insulin, okay, as well as drugs that would promote the secretion of insulin, such as sulfonylureas, okay. On top of that, our body will synthesize glucose as well. And this comes from the liver and also from the kidney. So people who have kidney disease and people who got liver disease are also at higher risk of developing hypoglycemia, particularly patients who've got chronic kidney disease, because this is also the organ where drugs are being cleared. Okay, so people are treated with insulin, people are treated with sulfonylurea, and people who have chronic kidney or liver disease. And the other high-risk group are those who are frail, who got a lot of, who might not have the cognitive dysfunction, maybe, and also people who are not very compliant in terms of treatment. These are the people who are at risk of having hypoglycemia.
Well, I mean, it's really interesting you say that because I was an accident and emergency doctor, Fernando, and, we used to see people coming through the doors and you never really knew what was wrong with them. And hypoglycemia can manifest in many ways, can't it? So in terms, just talk us through the symptoms of hypoglycemia and what clinicians should look for.
Yes, when you are going down below 70 milligrams per deciliter, you can have the initiation of the symptoms. And when you reach the level of 54, you will be having the response of the hormones that are prone to elevate the glucose. You will be having the symptoms of adrenaline, like tachycardia, sweating, shaking. Then you will be having hunger, because you want to restore the homeostasis of the glucose. And if you are going down of 54, you can lose your ability to control your conscious. And the patients can have a seizure or can have a different grades of nebulation to come. then this is the neurogleukopenia symptoms.
And for me, that's the most interesting. So we would have patients who come in who'd had seizures, who were confused, who were not able to give a proper history, maybe just drowsy. And of course, you wouldn't necessarily know to look for hypoglycemia. I mean, obviously, we would do it as a routine test.
Yes. And there is happening that we have levels of different kinds of hypoglycemia. You can say this value of lower than 70 milligrams per deciliter is a suspect for hypoglycemia. If you have less than 54, you will be having a hypoglycemia that can put in risk your life. And severe hypoglycemia is when you need a third person to take care of you to restore the glycemia.
But Fernando, these levels are individualistic. They cannot, it's not one size fits all. So some patients will react even at higher levels. So it depends upon the patient that you are following up.
So let me just ask you, so say for example you had a type 1 diabetic that comes into hospital, obviously you might suspect hypoglycemia, but are there atypical presentations of hypoglycemia in diabetic patients in type 1 and type 2?
Yes, they are, because most of what Fernando described as neuroglycopenic symptoms, they all depend upon the capacity of the patient to be able to control glucose hemostasis at a certain level. But we also know that within some patients, they might have asymptomatic hypoglycemia. No symptoms, nothing whatsoever. But then they have severe hypoglycemia.
So why would they be asymptomatic, though?
One of the reasons they have is that some of them are prone to supporting hypoglycemia in one way or the other, because we are talking about physiology here. Physiology and pathophysiology cannot be cutting across every patient. Some patients react differently to other patients. So they might have a certain degree of hypoglycemia, but it will not manifest in terms of what we talked about, neuroglycopenic symptoms. But others would have severe hypoglycemia. And when you start talking about severe hypoglycemia, it's not necessarily only in terms of the level of hypoglycemia, but it's also associated with the symptoms that the patient would present, with some of the symptoms Fernando has already mentioned.
So is it possible for a patient to be cogent and cognizant and then suddenly to be drowsy?
Oh, yes, of course. It depends upon how well your blood glucose is drowning. Because when you start reacting, those asymptomatic, it has gone to a certain level. And then when you become severe, it means it has gone lower. And then at that stage, you can go to severe, needing hospitalization. Therefore, the third person comes in now to be able to recognize that you have. And sometimes they're in a coma, hypoglycemic coma.
I've seen it.
And that is important for us to know. And most of what happens in some of these patients because of hypoglycemia is that they have to discontinue the treatment that they're doing, because the hypoglycemia is related to the type of treatment that they're taking. So if you have somebody on insulin, the person will say, every time I take this dose of insulin, I have the symptoms. If you have somebody, as Juliana said, on sulfonylureas, every time I take the sulfonylureas, 1 or 2 hours later, I go into having these symptoms. So the patients now would have to discontinue some of the therapy because of the hypoglycemia.
Right. So given these atypical presentations, Juliana, do you think hypoglycemia is underdiagnosed?
Yes, I think, some of these patients who have long disease duration, they lose that symptomatic sympathetic nervous system activation. So these are very important signs, right? Warning signs. You feel hungry, you feel anxious, you go and grab some sugar drinks. So with prolonged disease duration, some of these people lose this, right? And in people who might be very tightly controlled, they get used to the hypoglycemia, so they also don't do that. And then what happened is the blood sugar continues to fall, and then suddenly they have this neuroglycopenic. They feel sort of dizzy, they even lose consciousness. So I think doctors need to ask about this every time, at their visits, and also explain to the patients, the nature of hypoglycemia and what are the symptoms. Sometimes some of these patients, they just don't look themselves.
Yes.
You know, they are conscious, but they may be, you know, they're having temper tantrums, they may be scolding people, right?
Yeah.
You know,
And who reports that? The family?
yes, maybe the family.
Yeah.
So it's not him, right? He's very irritable. And then sometimes you feel their hands, they're very sweaty, so you know they're having autonomic dysfunction. So I think these are really subtle signs that the good thing is, the important thing is just prick the fingers.
Yeah.
You know, and then you know.
Fernando?
One another point on this is the patients who has neuropathy. Because if they have neuropathy, the response is different.
Yeah.
And as Juliana said, large evolution of diabetes can have microvascular complications and neuropathy. And in these patients, the recognition of the hypoglycemia is difficult.
That's a really, really good point.
And then again, sometimes patients would discover it when they're driving.
Yes.
Suddenly they come, they cannot see, double vision and everything. The intelligent ones who already have been educated would stop their car, but the others would enter into an accident.
Which, of course, would be horrific.
Sometimes fatal.
But that obviously, yeah, so they obviously have to be told to look if you have any visual blurring, any change in your vision at all. You stop, you pull over, you take glucose.
And this is where the individualization comes in. The elderly patients, for example, they're not so good in articulating, for example.
Of course.
And this is where you have to maximize the benefit and minimize the harm. So this is really where the individualization comes in. You need to know, you know, the risk profile of your patients. And rather than in these situations, maybe the tight control might do more harm than actually, you know, the long-term benefit. For young people, you know, because they have long disease duration, you really want to, you know, maintain good glycemic control. You teach them about what is hypoglycemic symptoms, tell them what are the things that will precipitate it and avoid it. So I think this is really where you need a very two-way interactions.
Yeah. Okay, I want to move on now to talk about the IDMPS study, the International Diabetes Management Practice Study. Juliana, could you just remind us what it is? And, you know, it's extraordinary in the size of it.
Well, this is the largest observational survey of people with diabetes living outside, you know, North America and also Europe. And the idea is really to document the clinical profile, the complications, the risk factors, the care processes, you know, what are some of the side effects, the medication profile, etc., in order to tell us, you know, in order to help the practitioners and also the patients to be more aware, you know, about the challenges of living with diabetes.
I mean, I was staggered to read it. It was something like 12 years so far, isn't it? 7 waves.
That's right.
48 countries and 72,000 patients. That's a big sample size.
It is an enormous database and it's very rich. And the important point is, you know, the majority of people with diabetes will come from the developing countries where data is scarce. And in this regard, I think IDMPS is a very rich resource, you know, of information regarding the impact of diabetes on people living in those areas. And in fact, there is a website which is called simply idmps.org. And I think, you know, people can visit, you know, where we have given some very nice summary about the key findings in this survey.
Great. Well, we talked about the different waves of it, but the last, as far as I'm aware, the last survey was about hypoglycemia. So what were the main results of this?
Yeah, if you look at hypoglycemia, and that is wave 7, and I want to classify it, as we've said, in asymptomatic, symptomatic. In type 1 diabetes, about 59% of our patients had asymptomatic hypoglycemia, whereas in type 2 diabetes, you had about 32% of the people. Now, if you go to severe hypoglycemia, as we mentioned, is patient-dependent, and also the degree of hypoglycemia, you have about 16% in type 1 and 6.3%.
And how many?
6.3% in type 2. And then now if you go to severe hypoglycemia needing hospitalization, which means the patient can become unconscious or the family is concerned and they have to admit the patients because of hypoglycemia, you have 17% in type 1 and 7.9% in type 2. I cannot stop discussing in terms of the statistics as found in the wave 7 without mentioning patients with hypoglycemia, and they have been forced to discontinue with their treatment because of hypoglycemia, and that is about 15% in type 1 and 13% in type 2.
Were you surprised by these figures?
Not really.
Really?
Yeah,
Hypoglycemia,
because-
59% in type 1 in asymptomatic.
Because these patients on insulin and adjustments of the dose of insulin or taking insulin without a proper meal would cause hypoglycemia. So we are not surprised. And why are we not surprised? Because we work in the real world. We are not in experimental conditions.
No, sure.
Because exactly that is obviously what we see in our clinics, that most patients, especially the young ones with labile, in terms of character, in terms of needs, were on insulin. Sometimes they'll go to school, they don't have the food to eat, and they take the insulin. If you have diabetes and you take insulin, glucose has to come from somewhere, and when the somewhere means you have hypoglycemia.
So let me just ask, I don't know which of you wants to answer this, but in terms of the figures that have just been quoted, how do they compare with the US, with European cities? Is it similar?
It's similar. We don't have different figures on that, because patients who use sulfonylureas and patients who use insulin are on risk of having diabetes, having hypoglycemia.
Right.
One of the points that Jean-Claude said about discontinuation of treatment, I think that is not only discontinuation. They are lowering the dose, and this is producing bad results for the patients, because if you don't intensify the treatment, you are going down on the dose of the insulin, you will be obtaining bad control.
Yes.
And if you don't reach the target, you will be more prone to develop complications, the chronic complications of diabetes.
Of course, the macrovascular, microvascular.
And the patients who experience one hypoglycemia or severe hypoglycemia don't want to have another.
Yeah.
Yes, and
It's very disturbing.
Yes.
Of course.
When you see patients saying that, I'm afraid to go to this reception because the last time I was there, I fell. And then, you know, the connotation, people think it's epilepsy.
Yes.
And then nobody wants to be identified as being epileptic. So these things, and then sometimes hypoglycemia would cause people to have things associated with, like, with epileptic fits.
Yeah.
And in some areas of the world, that is a taboo.
Of course.
To be identified.
And I suppose there are cultural connotations with being overcome by spirits and all the rest of it, yeah.
I didn't know you were so conversant with spirits, you know.
I am.
And this is part of the impact of the hypoglycemia, the impact that this have in the social life of the patients.
Yeah.
Because it can happen on the work, it can happen on a party or in your home. And you will be vulnerable because you need someone to attend you in the severe hypoglycemia.
Okay, well, let's just talk about glycemic control in this study. So what level of glycemic control was achieved, Juliana?
Well, in this last wave of IDMPS, about 20% of people with type 1 diabetes achieved the A1C less than 7%, the sort of generally accepted targets. Among the type 2 diabetic patients, it's around 30% or so. But it varies from like 50% in those who are treated with drugs, oral drugs,
Yeah.
to less than 15% in those who are treated with insulin.
And do you think the reason for that is because people are worried about the insulin dependence, that they're worried that they might become hypoglycemic, so don't take their insulin?
Certainly, fear of hypoglycemia is a major, reason.
Yeah.
People might not omit it altogether. They might cut back. You see, and also doctors might not be willing to titrate so intensively if these patients are actually having experience of hypoglycemia.
And that's very interesting, Juliana, because one of the phobia of using insulin by physicians is that they're afraid that the patients will go into hypoglycemia.
Yes.
And you know what happens? You're a bad doctor. So they don't want to be classified as bad doctors.
So,
And manipulation of insulin is a very tricky thing with general practitioners.
So basically, you've then got two parties worried. So you've got the doctor worried,
yes.
the patient worried.
Yeah.
So the blame could be between them, or
Yes, and that's why when we are looking at hypoglycemia, we look at physician factors, patient factors, and we try to differentiate them between. If you have a patient, for example, a physician, and you put the patient on insulin, it is well understood that you must discuss hypoglycemia with the patient, and if possibly, make the patient to feel a bit of hypoglycemia so that when the patient feels this, because if you don't know that,
what
you have
signs
to take
to
a
look for?
bottle of a drink, a sugary drink, when you have hypoglycemia, then when they come, they say, what is happening to me today? But if you've gone a little bit and the patient has experienced neuroglycopenic symptoms, as we say, sweating, heartbeat, double vision, lack of concentration, then when the patient says, that's what my doctor talked about, it's hypoglycemia.
Yes. So let's just talk about hypoglycemia generally, because it's not obviously just that acute event, is it? You know, in terms of mortality, it's a very significant, it's very acute, it's a very serious metabolic emergency.
Yes, because there is a different mechanism in which with the hypoglycemia you can have a response on the cardiovascular system. And one of the responses during the day you can have tachycardia or arrhythmia. But in the night, if the hypoglycemia is nocturnal, you can go with bradycardia and arrhythmia. And this can be happen as a sudden death for the patients.
Right.
And the response is different during the day to the hypoglycemia.
Yes.
On the other hand, you know, I mean, it is now well recognized that people with hypoglycemia are at a higher risk of developing major complications. They have increased risk of all-cause death, they have increased risk of cardiovascular diseases and other comorbidities. So it's sometimes difficult to, you know, dissect the relationship because people who've got comorbidities, as I already explained, are also at higher risk of hypoglycemia, particularly people who've got chronic kidney disease. So at the end of the day, we don't know whether it was the chronic kidney disease causing it, you know, all the sorts of bad outcomes. But the point we want to make is really, it is a complex issues. So, you know, understanding the patient's risk profile, elderly, long disease duration, chronic kidney disease, comorbidities, you know, people who are not so good cognitively, this is really where you have to have your clinical judgment. The art of medicine comes in, so that, on the other hand, you don't want to, you know, so stop treatment, right? Because these people, if they go hyperglycemic, they also have problems. They can have sepsis, they can have coma.
So
really
in fact, you're saying that
range.
hypoglycemia itself, excuse me, isn't necessarily a failing of treatment. It could be the comorbidities, it could be the fact you've got all sorts of other things going on.
That's right.
Especially in the elderly.
Yeah.
Yes.
And there is a marker of risk. If you have a patient who has a severe hypoglycemia, he has a marker for cardiovascular disease and death. And this is the reason that it is important to recognize that the patients can have hypoglycemia and asymptomatic hypoglycemia, like Jacques said at the beginning.
And then again, that is why in the elderly, we are not so stringent about reaching A1C glycemic control of 7%.
Yeah.
You have to put it a little bit higher.
Well, also, I mean, they have, you know, without being rude, they have a shorter duration of life. So
No, it's not the shorter, there's no duration of life.
Well, I mean,
it's because of the comorbidities. You ignite, as Juliana said, you start hypoglycemia in an elderly, you have defibrillation, you have death.
Yes.
Sudden death.
Yes.
So you don't want the patient to have either a myocardial infarction due to treatment. So you put the A1C a little bit higher, 7.5, some 7.8. I have patients that I put them on 8 because whenever I go lower, they start having a crisis. So it's individualistic. You have to study your patients, know their lifestyle, know where they are in terms of comorbidity, and make sure, when you manage patients, you want them to have a better quality of life.
And this goes back to treating patients as individuals.
Yeah, exactly.
Yes. This is what the guidelines say to us, that you have to individualize the goals for the patients and the treatments. And for the patients who are in high risk, you have to look for the therapies that has the lower rates of hypoglycemia.
Yes. So let's take a step back, because you all represent different parts of the world. What is the global impact of hypoglycemia?
Well, as we said, you know, hypoglycemia, particularly when it is severe, you know, it can actually call, you know, you have to be admitted to the hospitals. So that is, you know, of course, a utilization of the healthcare resources. Sometimes people with hypoglycemia might actually precipitate, you know, it is possible that it might precipitate other events, for example, cardiovascular disease. And but by the time you actually check the glucose, it might have already counter-regulate. So we don't know exactly, you know, whether, so people who are very tightly controlled, and then if they, you know, they have a heart attack or something like that, sometimes you might have to rethink a little bit, right? So I think there are really, and so I think these people, you know, you need to readjust the treatment, to reassess the patient, and then, you know, try to minimize the risk of hypoglycemia.
Do we know what sort of numbers are hospitalized?
It's difficult to know because some people, when they are hospitalized, they don't say they have hypoglycemia. But to pick on David on your last question, one of the things which is coming out in the literature is the effect of hypoglycemia, multiple hypoglycemia on the brain, degeneration of the brain.
Yes.
And that we have lots of public evidence now to demonstrate that this can cause even psychiatric disorders in people.
So that's interesting. So if that is the case, then obviously the global cost to health is even bigger than we thought.
Exactly. So
Yes.
hypoglycemia per se
Yeah.
is extremely dangerous because the rates of mortality are extremely high. You can have a blood glucose of 10 millimoles, 9 millimoles, 8 millimoles, and you support it. And it's the long duration of running 8 or 8 millimoles that it will have a long-term effect on their vital organs. But if you have repeated hypoglycemia, what will happen is that the next thing you can have is a sudden death.
When you review the literature, you can see that the admissions to the ER with drugs are with two, anticoagulants and insulin.
Yes.
And
Yeah.
the next is sulfonylureas.
Yes.
And this is representing a very high cost of the attention because this is the first causes of going to the ER.
Okay, well, let me just standardize it. What do the international guidelines say with regards to preventing hypoglycemia, both in type 1 and type 2?
I think the important point is education. You know, I think the education is, I think all people, particularly since insulin is a very powerful drug, right? It helps to, you know, control glucose. At the same time, it has a side effect. So people who are started on insulin, they need to go through an education program, not only learning how to administer, how to titrate, they need to understand what are the situations that will actually bring about a hypoglycemic event. Omitting meal, doing too much exercise, right? So I think they need to go through educations, and most importantly, they need to know what to do when they start having, you know, these kind of symptoms.
But it's so interesting. Education, it comes out every single time.
Yeah, exactly.
Doesn't it?
Because the problem is, I would prefer not to put a patient on insulin that I've not educated than put a patient on insulin where the patient does not know what to do in terms of dosing, in terms of when I have physical activity, in terms of when I cannot eat, in terms of whether I have a chest infection. So these are the things it's a class. You have to be able to empower.
So, but do you give your patients a sort of ABC of what to do?
Yes.
Yes, we have to train the patients. And Juliana says something which is very important, titration, because you can titrate the insulin up or down. Because if you are having hypoglycemia, you have to train the patients to go down on the dose of insulin in order to prevent the hypoglycemias.
And okay, let's ask you a tricky question. Of your patients, what percentage do you think are well controlled, have good education, work well with you as clinicians?
Mine is about 20%.
Is it? That's very honest.
Yeah.
Depends on the country.
You're obfuscating.
Depends on the country, because if I say the data of my country, I say 25% of the population has A1C less than 7. And in people who use insulin, it's like 15 to 17%. It's lower.
Yeah.
Because this is the patients who have more evolution time of diabetes and has complications, and they don't achieve the target very easy. And but if I saw my consult, it's different, because as a specialist, we are trained to train the patients.
Of course.
And this is the difference in our consults. But when you show the data of the countries, is that figure.
Juliana, the boys have been very honest.
Well, we're quite lucky in Hong Kong because we have a lot of diabetes center. and we have lots of diabetes educators. So I think the mean A1C in our population under the public care system is about 7.3 or 7.4%. So quite a lot of people are actually on target, and they always have access to education. But even then, hypoglycemia is not uncommon. Yeah, maybe the rate of severe hypoglycemia requiring admission is like, for example, 1% per 100 patient year. So that is really quite a lot of the sort of rates in developed countries. But I think in IDMPS, it can be as high as 6%,
Wow.
6 per 100 patient year. So it really reflects the importance of education, having some kind of system, a support system. So of course we can always do better. Sometimes, more and more patients are coming to the centers. We are quite overwhelmed.
Yes,
So
I'm
they
sure.
start to deteriorate.
And that's actually the beauty of IDMPS. You can take Hong Kong, then you take Cameroon.
Yes, that's true.
And then the factors are, what are the factors that has influenced Hong Kong getting their A1Cs at 7.3, 7.4? And what are we not doing in Cameroon to achieve that? You always have a comparator. And in life, when you have a comparator, it means you aim to do better.
Yes.
But if you think you are living in your ivory tower and you are achieving 8%, to you that might be a maximum. But whereas when you have the across the board in IDMPS, then you can say, no, but people are doing better than we are. So why are they achieving such goals?
But also you have country-specific challenges. I mean, Cameroon has bigger problems in some respects than Hong Kong does.
Yeah, but then the problem about it is that it might be that Hong Kong educated their patients better. So it might not be a question of affordability, of poverty, of everything, lack of access. It will be that if you educate your patients better, you can do something to tip the A1C to the lower side rather than wait and say we don't have. Because the denial system in our healthcare systems are really outrageous.
Yeah.
Why do I say so? People sit in their office and say, we don't have this, we don't have that, we don't have this, and therefore we cannot do anything. So the patient should die. That should not be it.
No.
We're trained as medical doctors to save life, not to precipitate life, a death.
I have to wrap this up now. What were you going to say just before I do?
Yes, when patients has more time of diabetes, usually they have to use insulin, and you will be having the risk of hypoglycemia. And with the people with diabetes now getting older, we'll be seeing more patients with hypoglycemia.
Yes.
And I think that we have to be prepared to that.
Well, so let's try and just wrap this up. If there was one take-home message for, clinicians around the world watching this, Juliana, what would your take-home message be?
I think know your patients well and balance the risk and benefit and educate the patients and monitor them and, try to get the right balance for this particular patient.
And individualize.
That's right, individualize your treatment goals.
Yes, Fernando.
Look for hypoglycemia symptoms in your patients, because so many physicians don't look for the symptoms of hypoglycemia. And you have to look for that and question the patients on the symptoms in order to recognize that the patient has hypoglycemia.
Sage words. Jean-Claude.
I think quality of life of the patient must be taken into consideration. And how the hypoglycemia actually affects the patient quality of life. It might be the tipping point between continuation of treatment or discontinuation of treatment. And so what we have to do is a proper history, proper education, and therefore we prevent that tipping point.
Fantastic. Thank you so much to all of you. I know you're desperate to get back to the convention, so I'll let you go at this point. Thank you very much indeed.
Thank you.
Thank you, David.
And
so much,
that
David.
brings our debate on diabetes, real-world experience, and hypoglycemia to an end. We'll see you very soon for another debate on diabetes. Until then, from me, goodbye.